All right, hello everyone. I'm Katie Johnston from the Boston Globe. Thanks for joining us. See, some people still have not made it through the lunch line, so I'm glad you guys did. So today we're going to be talking about the executive orders that President Trump signed right after he got into office, aiming to eliminate diversity, equity, and inclusion initiatives at the federal level, as well as among private employers. And this could obviously have a huge impact on healthcare, including the delivery of culturally responsive care and the ability to hire a workforce that represents the community. So we have a great panel of experts here today to dive into all this. So I'm just going to ask each of you to just introduce yourself briefly before we get to the questions.
I'm John McDonough. I'm a professor of practice at the Harvard Chan School of Public Health in Boston.
Hello, my name's Mimi Gardner, and I am the Chief Equity Officer at NeighborHealth.
Hi, I'm Sean Cahill. I'm Director of Health Policy Research at the Fenway Institute at Fenway Community Health Center in Boston.
So, John, I'd like to start off, if you would mind, just like setting the scene for us. If you can just walk us through, how does diversity, equity, inclusion fit into healthcare? Is it necessary to consider these factors to provide the best care, and how could eliminating them affect healthcare?
So, thanks. That's a
easy question.
Deep, big question, and we could spend 2 hours just on that, but I'll try to do it in about 2 minutes. But I think it's really valuable and important to understand a little bit of the essential history here over decades. So just real briefly, you know, we, in the United States, we have a long history of inequitable and unfair and unjust healthcare in our system, and there's so many examples. Just the Tuskegee medical experiment in the 1930s that put 400 black males in a syphilis test to try to figure out what happens if you don't give any treatment to Negro males. And by 1947, there was a cure, and they deliberately did not give the cure to the people in the study because they didn't want to disrupt the study. And so these folks went on for decades not getting care while there was a cure right there available. Just a classic case of extraordinary irresponsibility. And I think it was about 28 died from syphilis, 100 died from complications, plus 40 wives and 19 children died. So that's number one example. Number two example, it wasn't until 1966 that all hospitals in the United States were desegregated. You go back to 1965, and more than half of hospitals in the southern states were racially segregated. Either black folks could not go into that facility, or there was a separate part of the facility. And it took the creation of the Civil Rights Act in '64 and Medicare in '65 to break that stranglehold and get rid of it and open up. So there's a long history here. It wasn't until the mid-1980s with, in the Reagan administration, and Secretary of Health Margaret Heckler put out the first report ever on the health of black Americans, estimating that about 60,000 people a year lost their lives because of poor treatment, because of discrimination. So a landmark at the same time when it came to solutions, it said, well, we need to educate people and we need them to take more personal responsibility. Nothing about the larger picture. It wasn't until the late 90s, Surgeon General David Satcher really made racial and ethnic health disparities part of the lexicon and established the standard where, for example, you couldn't apply to the NIH for a grant unless you addressed inequities and disparities in the system or explained why it wasn't relevant. And then in 2002, there was the landmark study from the Institute of Medicine on unequal treatment, confronting racial and ethnic disparities in healthcare. And so it's been this century, really, where we've made tremendous advances and stunning progress in so many different ways, particularly since the George Floyd murder in 2020. And DEI is a strategy to deal with discrimination, both conscious racism, but particularly unconscious racism, which has been scientifically demonstrated. And so we have a responsibility, all of us, to address this, because the health and well-being of non-whites in American society is a concern, a responsibility, an obligation for everybody. And if we're ever going to try to improve our system so we're not a disgrace on an international level, as we are, then we got to be about addressing this issue and this need. So I'll stop there.
That was great. I just learned a lot. I don't know about you guys. Well, so maybe I wonder if you could talk about DEI versus equity. These orders seem to be conflating the two concepts, the executive orders. Can you explain how they differ and how health equity is getting swept up in the anti-DEI movement?
Definitely. What I wanted to start out with, though, is one of the things that I was in a training in that they said, do not say DEI, say diversity, equity, and inclusion. Always spell out the terminology. And with diversity, equity, inclusion initiatives, I have to listen to it too. It is more about, the primary focus is on fairness, respect, inclusion, and equal opportunity across various contexts. Health equity initiatives are more so a fair and just opportunity for everyone to achieve their highest level of health. With diversity, equity, inclusion, we're looking at the workplace, we're looking at education, and we're looking at the broader society. In health equity, we're looking at the healthcare systems and factors influencing health. Key objectives for diversity, equity, inclusion are representation, equitable treatment, belonging, and valuing diverse perspectives. For health equity, we're looking at eliminating health disparities, addressing social determinants of health, and achieving equal health care outcomes. There is some overlap, and the overlap is that you need staff who are well-versed in diversity, equity, inclusion. They need to know about cultural competency. They need to know about unconscious unbiased. They need, or bias, unconscious bias. They need to be able to understand where our patients are coming from. And for equity, we need to look at the health disparities, looking at how the patients we serve, how the community we serve are affected by disease when it breaks down to racial or ethnic groups, and how best that they need care to address things. So I'll use an example of the Black maternal health, which we just went through, and we're looking at how Black women are more likely to suffer morbidity or mortality, and that has a lot to do with their genetics as well as the social issues that they deal with social inequities. And so it's our jobs in doing this work to be able to be aware of these differences and the difference between the two, and to make sure that we're serving all of our patients and giving them the best quality care, because there are disadvantages just from racial groups. And there's many studies that have been done with NIH, with the Office of Minority Health, which have looked at these areas. When breast cancer, they've looked at it in terms of diabetes. They've looked at it, and a lot of this has been eliminated, but it's very important that these issues are covered, because these are the patients we see on a daily basis. And these issues are not going away. Health equity is here to stay, as well as diversity, equity, and inclusion.
Sean, I wonder if you can talk about data collection. It's also getting swept up in this eradication of diversity, equity, inclusion. Can you explain why identifying someone's race and ethnicity and sexual orientation and identity is crucial for understanding and treating health issues, facing different populations?
Yes, I'm happy to do that. We know that people experience disparities along the lines of race and ethnicity. There's also disparities affecting LGBTQ people. There's disparities in rural healthcare. So it's important to collect demographic data so that we can use that data to do population health management. So, for example, if we see that Black women are getting are not getting mammograms at the same rate as white women, which is true. Why is that? Why are they not accessing that care? We also see that lesbian women and lesbian and bisexual women are less likely to get a pap test than heterosexual women. We don't know why, but just knowing that basic fact allows us to target that disparity in accessing preventive health care and try to reduce and eliminate that disparity. So it's really critical, and there's been a real expansion in sexual orientation and gender identity data collection in this country over the last decade. It's increasingly the standard to collect that data and to use that data. It can also be used to inform clinical decision support and preventive screenings, like I said. But unfortunately, this administration is going in the opposite direction, and really rolling back LGBTQ health equity initiatives, including data collection.
Now, have Trump's anti-DEI directives had any impact on the organizations that the three of you belong to? And are you doing anything differently in the light of all this pushback? You could just take that one at a time. John, you want to go first?
Well, I'm from Harvard. And we're making a federal case of it. But we are facing about a loss literally of about $3 billion in research in all different directions on all kinds of things that have nothing to do with DEI or anti-Semitism at all. So it is, and we know because we heard the vice president say this 4 or 5 years ago on mic out in the open, we have to have an assault on America's universities. We have to bring them down and take over, and that's what they are attempting to do. So this is not about anti-Semitism. This is about, I think, anti-DEI. But more than that, this is part of a frontal assault of this administration on sectors of society that they feel that they don't have adequate power and control over.
Yes. For us, we lost one grant, which I believe was an NIH grant, which was through a university to us. And that was a grant which focused on post-COVID and education for people who have not gotten vaccines. And we were going to do motivational interviewing for those patients. So that's the only one as of now. In terms of the organization, we are monitoring it closely. I want to stress that a lot of what has happened, there are a lot of lawsuits that are swimming in the lanes regarding this DEI piece. And I think they need to also be careful because with the DEI, we cannot, and the law is saying that discrimination cannot be overlooked, so that they have to be very careful. But like I said, we're looking at it on a daily basis, but definitely there are threats.
In addition to the anti-diversity, equity, and inclusion executive order, there were a number of anti-transgender executive orders, and those are having a big impact on our ability to provide care. About a fifth of our patients at Fenway Health, we have about 33,000 patients, and about a fifth are transgender or gender diverse, non-binary. And I think the government singling that population out and demonizing them and attacking them in the way that they've done is very frightening for people. It makes people question their sense of belonging in society, their sense of safety. And there were already a lot of challenges and threats to transgender people before January of this year. And then we have a research institute at Fenway Health. I work in the research institute. We've lost at least 15 research grants totaling at least $4 million. And I personally lost 2 research grants that were worth over, one was a 5-year grant, one was a 2-year grant, and they were worth $1.5 million. So I think it's more than $4 million. And that's research, we were doing, we lost a lot of HIV research projects. One of them was with, to prevent HIV in women, and those are mostly straight women and disproportionately Black and Latina women who are affected by HIV in this country. So it's having a huge impact on our ability to do our work. And one thing that we're doing is scenario planning, and we're trying to think of how do we continue to serve the communities we serve, which include the transgender community. How do we continue to provide healthcare to them? And so we're paying very close attention to what's coming out of the administration, and also working closely with our state partners to ensure that we can continue to provide care.
Wow. Mimi, you recently went to a conference where a list of acceptable words were shared, words that could still be used on grant applications that wouldn't be flagged as promoting DEI, but could still provide health equity. I wonder if you could share some of those words.
Yes, the list has over 50 words, so
So maybe not all
No,
of them.
not all of them. So anyway, diversity and inclusion should be changed to system-level challenges. Disparity should be changed to gaps. Using the terms diversity and equity, broadening participation. Equality, participation from all people. I had to write them down because I wouldn't remember this. Equity, balance. Immigration, identified populations. Inclusivity, participation from all people. Marginalize, low access groups. This is my favorite. Social determinants of health, non-clinical factors of health. And then lastly, and I'm sure everybody knows, is DEI hiring, merit-based hiring. Okay? So these are words that they expect to be in anything that's federally funded. And like I said, the lists are on the internet, so you can actually find them. And like I said, there's over 50 words. And so anybody who has federal funding or any grants that you were writing for coming up in the future, you are not to use the initial words that I said. And you're to use the acceptable words.
Do you think that that could hurt diversity and equity in care to use this kind of coded language?
Yes, it will definitely hurt the work we're doing. It will definitely mute the message that we're trying to get out there. We work with our patients and our communities are diverse, and they need the services. And so my recommendations to everybody is when you're working with these communities, you need to be listening to what they have to say. You need to be also not changing the quality that you are providing to your patients. You need to talk to the legislators, your local politicians about the work that you do. They need to know. I was recently in DC and they talked to us and asked us, give us stories. Tell us what is going on. We need to know so we can bring this back to Congress. So I invite all of you to also talk to your grassroots organizations. Keep your ear on the ground with them, support them, because they are affected by a lot of this more so than some of our organizations. They're smaller, so one loss of a grant could close their doors. So please work with them and listen to them and bring up their voices, because I think if you're able to bring up their voices, they will withstand however long this is going to go on.
Wow. Sean, are there instances of places that are being overly compliant with these orders or even embracing Trump's directives?
Yeah, I think the cancellation of the research grants is a good example. The orders are anti-transgender, but there's a lot of research grants that are about gay, lesbian, and bisexual people that are being canceled. There's research grants that are about HIV. Now, HIV disproportionately burdens in this country and in the Western Hemisphere gay, lesbian, bisexual, and transgender people, but anyone can get HIV, and many heterosexual people get HIV. So, but those have been canceled. I think there's a lot of confusion, and people are trying to interpret these very vague executive orders. They have often language that can be interpreted as threatening. We're also seeing letters coming from CMS to state Medicaid directors that are, again, very vague and sort of implying that state Medicaid departments are assuming all this liability if they continue to provide gender-affirming care or to use Medicaid funding to support gender-affirming care. I know of 2 instances in New York and Illinois where gender-affirming care for minors is legal, where healthcare providers have stopped providing that care, probably in reaction to the executive orders. The CDC, Centers for Disease Control, took data and information about racial and ethnic disparities off of its website, information about how HIV disproportionately burdens Black Americans, for example, took information about LGBTQ disparities off its website. I'm worried that healthcare providers who are collecting these data and using them to provide quality care and to know how they're serving different patients, different communities, I'm worried that they're going to stop collecting racial ethnic data, stop collecting sexual orientation, gender identity data, and other data because of anti-diversity, equity, inclusion rhetoric, So that's the concern, and I know that that's happening. I know that that's happening around the country.
Wow. Yeah. Okay. So major implications here. Well, it looks like we're out of time. I don't know if there's anything else you guys want to add. It was very quick, but all right, John, you go. Last word.
This too shall pass. I've seen this so many times. Whenever you're in a really down space, it feels like it's going to go on forever, and it never will. It always gets. And whenever things are too good, it's never going to stay there. It's always going to go down. So just kind of those of you who are really justifiably upset and worn out and whatever, have courage, have faith. This too shall pass.
All right, go ahead.
Yeah. Okay. All right, Mimi. Last word, Mimi.
Okay. I just wanted to say the passion that brought you to this work, keep moving. The job needs to be done. There's so much out there that we could do, and I don't want people to, because of fear, and I think we said this in a meeting the other day, you have to be courageous. The work needs to be done. It's not just about us, it's about the communities that we serve. So keep it going. Last word from
Last
John.
point, a strong majority of Americans support diversity, equity, and inclusion, and they support equal rights for LGBT people. This administration is acting like it's 1964. President Trump's acting like he's President Lyndon Johnson. He did not win a landslide. He barely got a majority of the vote. So they're acting like they have this huge mandate, but they don't. And they don't represent what most Americans believe in.
All right. Thanks, everyone.